Good afternoon, everyone. Good afternoon, and welcome to this session on frontline perspectives on integrating PAs and AAs into multidisciplinary teams. My name is Claire Barton. I'm Assistant Director at the GMC with responsibility for bringing PAs and AAs to regulation. And I'm very pleased to be joined today by a fantastic panel who will be ready and willing to answer your questions. So those of you in the room and at home, please do submit questions via the app and we can get the panel talking in not too distant future. So I am joined today by Lee Varney, who is an anaesthesia associate who works at University College London Hospital NHS Foundation Trust. Lee is sat in the middle. Also Mr. Newman Shah, who is consultant trauma and orthopaedic surgeon at Salford Royal NHS Foundation Hospital Trust at the end, and Adam Thomas, who is a GP in Shropshire and Mid Wales. So we're going to start off by talking a little bit about scope of practice and supervision. And I'm going to start off by inviting Lee to just give us a little bit of background about how he as an AA explains his scope of practice and what supervision means to him.
Beautiful stuff, isn't it? Good afternoon, everyone. Lovely to see you all. Lovely to be in public as well, and not just on a flat screen. So I work at UCLH, which is that building kind of over there somewhere, the big green Emerald Tower. If you read Twitter about 10 years ago, you'll recognise the Emerald Tower. I'm not going to tell you too much about the scope of practice because you can see it. It's all online and it's pretty dreary stuff to read because there's a whole load of things of you can't. So I thought I'd give you a vignette of how we work in the scope of practice at UCLH. I've been there since 2008, so we've kind of evolved that scope of practice over that time to do stuff that's quite out there and certainly outside of what is written in the scope of practice. And if you look at other hospitals that are doing, that have had AAs for 15 years now, there's very few of them that work within those confines. But there are a couple of caveats to that. There's a couple of sentences in the scope of practice that allows us to do that. And the first one is, it says on qualification. Well, 14 years ago when I had slightly less wrinkles and a bit more hair, we couldn't do anything at all because no one knew what we could do. We were told that we were only going to do ASA 1 and 2 and we'd have to have a consultant anaesthetist there all the time. So fast forward that 15 years where we're now doing regional anaesthesia, we're doing central neuraxial anaesthesia, we do 2-to-1 and 3-to-1 working. Even if you look in the scope of practice, it just says 2-to-1. But there are examples of 3-to-1 and there are very small examples of 4-to-1 working. So how do we do that? That's really difficult. The scope of practice says you can't. There's a very nice little grey sentence that says, unless you develop local governance. So we've taken that and we've developed quite a lot of local governance. So for CDs or for interested parties wanting to introduce AAs, look for that sentence because that gives you your scope. It also adds reference to the new AA curriculum, which will be published very soon, I think, Royal College of Anaesthetists and the GMC, and I think a bit from UCLH. I think we've all kind of pulled some information together. And if you look at that curriculum, it's very different from the scope of practice. So, for instance, regional anaesthesia is in the curriculum. Central neuraxial blockade is in the curriculum, but it's not in the scope of practice. So I think moving forward, if you use the scope of practice to your advantage, you can have a very well-established AA workforce that you can deploy without necessarily sticking to the scope of practice if you look at all of the things that we can't do. Look at the things that we can do. In terms of supervision, how do we do that? So for my hospital, I've got a lead anaesthetist that's called the duty anaesthetist, and they're responsible for all anaesthesia at UCLH, but not clinically. So they'll go around and be the administrating anaesthetist. They'll sort any problems out, but they are my supervisor. Now, I work in interventional radiology about 80% of my time, which is a floor below the main theatre. So I have to know that my duty anaesthetist is free if I need them, and they need to know what I'm doing at the same time. So key for AAs is this two-way communication. So I have to know where they are, they have to know what I'm doing. Luckily, we've got a very good hospital electronic health record called Epic, so they can log into their phones and see what I'm doing. Apart from seeing me, they can see their anaesthetic given by my hand. So some hospitals have embraced that. Other hospitals we're still waiting to come on. The nice thing about having GMC regulation in a year's time, hopefully, maybe a little bit longer, is that the scope of practice that you can see now is probably just going to just move away, because the thing that's held us back is regulation, as you can probably imagine. So I'm regulated by the NMC. I stopped nursing in 2004. So my colleague who I work with has never been regulated. So until that disparity of workforce is sorted, that scope of practice is there just to keep everything safe. But that will change. There's no doubt that that will change. So for instance, in 2008, the AAs in Birmingham set up a regional block room that taught the medical trainees how to do their regional anaesthesia block. So that's an innovative way of using your AA workforce. Now that's totally outside of the scope of practice if you read it, but it's not if you look at the next sentence that says, unless you introduce local governance. Local governance is really easy. It's an SOP. I write an SOP for a spinal. It goes off to the clinical director. We put it through our local clinical governance group. If it's signed off, it's signed off. That is it. And then we are then able to do what we need to do. So until we get full regulation, we're still using the scope of practice, but there are very flexible ways you can use that scope of practice.
Thank you, Lee.
Okay.
And when anaesthesia associates come into regulation with the GMC, we'll also be taking on physician associates. And physician associates are generalists who work in many different arenas, both primary and secondary care. And Numa's going to tell us a little bit about what it's like working with PAs in secondary care, and again, focusing on the scope of practice and supervision. Over to you.
Thank you very much. Good afternoon, everybody. I'm just going to quick straw poll. Who knows what a physician associate is? Okay, great. So that's I'm not going to be hopefully covering too much old ground. I work up in Greater Manchester. It's past the M25, so hopefully you can find it on the map sometime. We've had physician associates at our trust, which is a level 1 trauma centre, a university teaching hospital, for the last 4 to 5 years now. We probably employ about 20 to 25 physician associates in various departments around the whole hospital. In my department, trauma and orthopedics, we have 3, and that sometimes fluctuates to about 5 or even less sometimes. We've got full-time students who attend with us, who are first-year and second-year students as well. I sort of always, when people don't know about who PAs are, I do tell them, just to give them a little bit of, a bit of perspective, they sit between doctors and nurses. That's where I feel that they actually work best, in my opinion. So they're very good at following policy or protocol, be it on the wards, clinics, or in theatres. But they also have that extra aspect where they can actually problem solve, manage patients, formulate those plans, all, as Lee has already mentioned, done directly under supervision. So that is how we work at the moment. For example, we've got PAs who are on the wards who will be following around on ward rounds. We've also got PAs that will come to clinic with me and they'll see my hip and knee patients. They've even started doing injections now as well, which is done under supervision. And I think I will like to emphasize the scope of practice is, I take it quite flexibly, to be honest. And I feel that provided you've got really good governance and robust governance around how you manage your PAs in that, on the ward, in clinic or in theatres, then I feel you've got a very safe environment for yourself as a supervisor and also for your patients primarily. And the way we do it is, we know precisely what, we sort of fine-tuned it to such an extent now that, funny story, one of my colleagues said to me, one of our senior PAs is Tom. And he said, Tom, he's a good lad, isn't he? He's a good doctor. I said, he's not actually a doctor, he's a PA. He said, really? But he's so much better than all the rest. And I'm like, that's because he's been here so consistently. And we'll touch on that a bit later on as well. So what we've got the PAs doing really well now is being really well suited to the environment they're in. Apart from being in wards and clinics, they're in theatres with us as well. They'll be my first assistant if I'm doing, again, a hip or a knee replacement. So, and I strongly believe that this is a vocational pathway of training, i.e. on-the-job training. There is some bookwork that they can do, which is fantastic. We've got, surgical care practitioners who come through the nursing route. They've got their modules to do at university, etc. But the PAs don't have as such book or university teaching that they're required to do. But certainly from our point of view, we've got a robust governance system where we make sure that they've gone through certain aspects of supervised, for example, if they're doing, let's say, PICC lines is a new thing that we've started, particularly because we work in trauma, plastics, and also orthopedics. We've got some people come in who need long-term antibiotics, and we're finding that a number of patients were staying, the length of stay was about 5, 6, 7 days extra than what it needed to be. So we thought it's a great service that we can deliver it. They can piggyback onto the IV service in the hospital, do their training. Once they're done the training, they can help us with our long-term patients. But what they're also doing now is they're branching out to other parts and other parts of the hospital to provide that PICC line service as well. So overall, we're finding that we're using them very, very flexibly. And I think we're being very effective in reducing our length of stay. We're improving the patient experience and patient outcomes as a result as well. And I do find that we're always pushing the boundary somewhat, and I think that's where I see PAs as well. I think they're a fantastic, adjunct to our workforce, and we're really, I think we're in a time now where once they get regulated, we can hopefully, lose those shackles and chains of not being able to prescribe and, not do ionizing radiation. But they're a very, very effective part of the workforce for us now. And I think hopefully we can get the regulator as soon as possible. Thank you very much.
Thank you. Do keep your questions coming in, whether you're in the office, in the room here or at home. But I'm going to start off with a question to Adam. So how does it work for PAs in primary care? How do they, as Newman said there, someone said, oh, was that a doctor? No, it was a PA. So how do PAs explain that in primary care, and how are they supervised as well?
So in the practice that I work in two practices, and the practice that I work in that has used PAs for a good many years, there had to be quite a lot of patient education about who they were seeing. So things like using the practice newsletter. So we're dealing with a much smaller cohort of patients, I suppose, still in the thousands, but people who do come and see us more regularly, I suppose, built up relationships with the PAs quite a lot quicker than they would on a one-off visit in secondary care. But yeah, I mean, there was, and still, I'm sure it's the same in hospital. And this is obviously a sort of a subconscious bias, but a lot of the female PAs get mistaken as nurses, and the one male PA in our practice always gets mistaken for a GP, and it's never been the other way around, which is shocking in 2022. But yeah, it's about patient education and understanding where they fit in the team. In terms of supervision. It very much depends on how the practice works, but I sort of canvassed a few of the partners that I work with, and the way they see it is, as long as you think of a PA in primary care as around the same level of supervision required as a GP trainee, then it actually becomes quite easy to then know what level of supervision is required. So as long as there's time built into the GP's day, because I supervise PAs when I'm the duty doctor on call, as long as there's time built in to debrief and discuss difficult cases and provide feedback and debriefing, then the supervision actually comes quite naturally as part of the working day.
A question here, I'll pose this to Lee. So how do anaesthesia associates explain to patients what their role is and what they're there to do?
That's quite easy. I just say, my name's Lee Varney, I'm your anaesthesia associate. Okay. I work with Dr. whoever the day is, and we're going to look after you, and this is my colleague who's the ODP. The most important thing is I always wear a name badge that says anaesthesia associate. But very often, again, there's the bias that because I'm tall, white male, my colleague, who's actually the consultant, is looked upon as the nurse, and I'm looked upon as the consultant. So it's always quite embarrassing. So I'm always very clear. And I think it's really important that we keep, patients don't often know that anaesthetists are consultants. And you've got to be really clear when you're doing something that could potentially put a patient to harm on exactly what you're doing and what your role is. And the patient must know who's anaesthetising them, who's looking after them. So I always say, and I think probably all the AAs in the country do say, I don't think anyone's gone rogue yet. We would find out. Yeah, we would find out. It's part of the training as well. So we're training 6 at UCLH, excuse me. And, you know, every introduction to a patient is, I'm a trainee anaesthesia associate. So I think if you've got that as part of your MO from the start, yeah, you should be okay.
Excellent. So we've had a question come in. I'll ask Newman this question to start off with. So how can we improve doctors' awareness of what PAs and AAs can contribute so they are used to their full potential?
I think that's an interesting one. I think that's something that even 3-4 years down the line, we're still sort of trying to educate our own teams, because they change so often every 6 months or so. I think education is always going to be the cornerstone. And I think the more events that we can do, more roadshows we can do, you know, have the GMC out there, really, you know, explaining to people who are coming to conferences that this is what they do, and maybe have some sort of publication as well out there as well to explain what their role is. I think that the biggest challenge is not going to be the workforce, to be honest, because once you have a PA in your department, people know who they are very, very quickly, because they become very quickly the go-to person anyway. I think the challenge here is the actual general public. How do we actually get that information out to them and actually make them understand, you know, the nomenclature of, we're not meant to be using SHOs anymore, but we still use SHOs because it's the easiest way to explain what grouping that particular doctor sits in, for example. So I think it's a cultural, it's a generational change. It's going to take time, but we've got to be constantly at it. I think that's what I'm saying.
You mentioned there bringing the PA into the role. It's very easy. They're in the team. People know who they are immediately. I'd like to talk a little bit now perhaps about induction and integration, because there's a lot more around a multidisciplinary team and how it works. So if I could, I'm going to invite Adam to just talk a little bit about his perspectives of inducting and integrating PAs into the primary care team.
Yeah, I'll stand as well, so everybody else did. So I'm in a fortunate position where I work in 2 different practices. One that has embraced PAs for a good many years. That's based in Mid Wales. They've been quite forward-thinking in taking PAs on a good 4 or 5 years ago. And another practice that I work in Shropshire that's very much taking its first steps and has had its very first PA start with us. So I'm seeing how it works, inducting a new PA into a well-established practice that has had PAs for a good many years, and inducting a first PA in a role into a team that doesn't already know what a PA is, as you were saying. In the practice in Mid Wales that has a lot of experience, they're actually quite fortunate. I think it's the first practice in Wales that actually has a PA as a partner. So we have a partner that's alongside the GP partners, and he is the financial lead for the practice. And to be honest, there's not a lot that, other than prescribing, that he can't do that a GP would do. So we're in a very good position in that practice, because there is already a PA in a position of authority, a position of respect, and is doing most things that a GP would do. So actually, a new PA coming on board has a good idea of what they're aiming for. When you're bringing a PA into a practice that's never had a PA before, then I've seen that that's not been so successful. So as I was saying, in terms of the supervision, the model in the Mid Wales practice that's had PAs for a while is they've sort of done away with the old GP hierarchy. So the GP does everything, and then sort of the GP does everything, and everyone comes to the GP for sort of guidance. It's more of a GP consultant model. So the PAs there will go. They'll do lots of the letter processing, lots of the sort of blood test results. They will do care home visits. They will be at the patient bedside and video call the duty doctor when we're on, which gets away from the fact that a GP hasn't seen someone in many weeks if a patient sadly passes away. So they really are an integral part of the team. And the way we sort of are able to integrate them is that because we are looking after advanced nurse practitioners, PAs and GP trainees and medical students, there is that constant access to the GP to oversee the decisions, but can make and have those conversations with PAs to make sure that they're happy and not sort of stepping outside their scope of practice. In the practice that we haven't had a PA before, it's a case that, as I was saying, they're being treated a bit like having a GP trainee. So the GP that's looking after the PA has fewer patients booked in, so that there's time built into the day to debrief the patients that the PA sees. But that isn't as successful because we haven't had a PA before. But I think that's probably going to be the case in any department that has never had a PA before, because they're kind of blazing the trail themselves. In terms of the induction, it has been a lot more successful in the practice that's had a PA, because they take the lead on the induction for PAs. So you have a PA that's been in the role for a good many years, sits them down and sort of shows them the ropes. Whereas in the practice that they're new, that is being done by the GPs, who don't necessarily have much of experience working with PAs. So that's a bit like the blind leading the blind. In terms of integration, and I'm going a bit more to scope of practice there again. As I was saying, there's nothing other than prescribing that they can't do. So in the practice where they're well established, they're doing the 6 to 8 week baby checks. The PA who's a partner is doing minor surgery, joint injections. They're seeing undifferentiated patients in their clinics, and they are doing the regular sort of care home ward rounds. And the benefit of that is a lot of those roles is what classically would have been taken up by the GP registrars, and the GP registrars can be rotating 4 monthly, 6 monthly. So when a PA has been there for a good couple of years, they know the care homes well, they know the residents really well, and you're actually returning to the model or the environment that people are harking back to of, you know, your family GP and you see the same person and they know you inside out, and actually when you come in with something, they know if you're unwell or not because they know you so well. Well, because you've got the continuity of a PA there over a period of years, then you're able to return to that model of continuity when the GPs that are on call are seeing the more complex patients. So yeah, that's all I have to say.
Thank you.
Thank you.
And Newman, how does it work in secondary care? And you mentioned as well that I think you both mentioned the continuity of care that you get from PAs, and I think, you know, with doctors rotating, especially when they're in their training, you've got that constant presence of the PA in the team. So once they're inducted, and how do you then integrate when the team around them is changing, perhaps?
So I think I've used this before, where I feel our PAs have been absolutely fantastic. They become the memory of the department now. Where every 6 months, 4 months, you'd have foundation doctors, core trainees, etc. moving, you'd lose all that experience that they gained in the first few months, and then suddenly they're gone, and everyone's like scratching around to find, how do we get hold of that person, or how do we do that? So what we've had now is we're not having that brain drain or that amnesia that we have in the first 3-4 weeks of changeover. And that's been a godsend. That's been amazing for our patients, our doctors, our nurses. The nurses know exactly who to ask in the first couple of days or first week, or this is a problem, how do we sort that out, etc. Because the doctors are still, to be fair, still finding their feet, and that's normal. I've been through the rotations, and I know how difficult it is when you change over. So I think that's the first point. I think they have, once you get it, I think the first obstacle is getting that first PA into your department, and just convincing people that they're going to be very effective, they're going to be really good. Once you're over that first threshold, that first PA comes into your department, then it becomes easier, honestly. Once you've got that, we're now using our PAs to do the induction for our junior doctors. They'll come in and do a session about who they are, where they fit into the team. Integration has been a little bit challenging. I'll share a little story. So we had PAs working for us for a couple of years. We had 2 or 3 PAs doing really well. But then one of my colleagues, Ed, came and spoke to me and said, Newman, listen, I think we're having a problem on the ward rounds. I know, what problem are we having? I've not heard anything going on. He said, the PAs are running the ward rounds so well that the trainees that are coming in, the junior doctors, they're just taking a back seat. They'll follow the ward round around, but they won't really engage, and that's part of their training. He was head of junior doctors training, etc. So he had a vested interest in make sure they got trained well. And I said, well, I never even thought of that actually. And so I just sit my PAs down and told them, listen, I think you are a classic case of victims of your own success. You're so good, you know the patient so well, because we also provide a 7-day service with our PAs, that the junior doctors, the trainees, are not actually getting the training that they need. So they're all very gracious about it. They said, that's fine. We're willing to step back. We'll let them lead the ward round. I said, let them struggle. It's fine. If they say something wrong, then you step in, obviously. So, and that sort of, so we sort of went really integrated. And we found that we had to swing it back a little bit. And now we're probably in a little bit of a happier balance. And I think that's a happy problem to have, I think. It's not something that I worry about, but it's just that we do need to tweak where they fit and how they sit. And I think going forward, I certainly think once they're regulated, they'll be, I think that they're going to be really in demand, and I think they'll be even more effective and valuable as part of the workforce, I think.
Thank you. I mean, there's the potential there for tension, I think, between doctors and PAs. And we have had a question that's come in that said, have you noticed tension between doctors, PAs, AAs? Lee, have you encountered any tension?
We were, so from the very start, I think our mode of working is probably just slightly different to PAs in that it's slightly different to, so we were always under the kind of order that medical training comes before AA training, and that mantra has stayed pretty much actually throughout all of the training, certainly for our trainees as well. We are lucky enough to have a department big enough to take 40 odd trainees, some clinical fellows, and 6 AAs, 6 trainee AAs, and pretty much have everyone working doubled up with a consultant. Now, I know that doesn't happen very often. It's very, very important that as an AA knows that, so if I'm doubled up, and sometimes we get tripled up, I'm very happy because I can just go. I've got a whole load of stuff that I need to do because I don't get SPA time. I've got lots of stuff. But equally, if it's on a particular list, I can free the consultant up to teach the trainee something particularly super, and I can sit in theatre and very happily do the case. But you've got to be very aware, and this comes back to recruitment, and it'll probably be the same for PAs. You've got to know who you're recruiting as a PA and as an AA. You do not want someone that wants to be a non-medical anaesthetist, or a nurse anaesthetist, or an ODP anaesthetist. It's all coming back to who you get at interview. And you can screen those people out very, very easily, or you can work it out of them in the first 3 months. That's really key to make sure. It's really important that trainees get what they need to get. If you employ a correct working model, your PAs and AAs should enable that, much, much more than now. So at the minute, registrars might be just used for service provision. Certainly, I've seen a few of our registrars where there's no consultant next to their name, which means they're being used for service provision. Is that the best thing? Well, it's probably, they need to do their anaesthetics, but they probably there's some better lists that they could go on. So it's really important that is modelled into how PAs and AAs are worked into the department.
Adam, I'll ask you the same question. Have you experienced any tension in primary care between PAs and doctors?
No, because I think, coming back to what you've sort of both said, it's very important that that both us as the workforce and the public don't think that PAs are one size fits all. It's very much important that you see PAs as a profession the same as a doctor is a profession, and there are thousands of different types of doctors. There are different people who suit different roles. So there was an example in the practice that is experienced with PAs. We've now got 4 PAs, so one who's a partner and then 3. One who's relatively new, was a HCA at the practice, went away and trained and came back. Very much primary care focused. So just as not every medical student will make a great GP, not every medical student will make a great hospital doctor. It's exactly the same for PAs. So because they've had the PA training doesn't mean that they will be able to slot absolutely seamlessly into primary care as they would do in secondary care. So they did actually employ a PA who'd done quite a bit of secondary care, who wanted to have a go at primary care, and it just didn't work. And that wasn't anything wrong with the induction, there wasn't anything wrong with the environment, there wasn't any tension between the doctors. It was purely the person. It just wasn't a fit as a career. So I think it's important not to try and plug gaps with a PA, but actually find a PA who is suitable for that gap.
Fantastic, thank you. Lee, a couple of questions for you that have come in. So does UCLH indemnify the work of the AA, and what is the role of the consultants when AAs get into trouble? I'm sure AAs never get into trouble, but... and then the second question, how do the AAs at UCLH demonstrate ongoing learning and professional development?
Okay, so the first question was, we're covered by vicarious liability. So the trust... as long as we're working within our scope of practice and within our SOPs, the trust will indemnify us. as I would if I was not an AA and I was a nurse. That as long as I'm working within my area of expertise and I'm not doing anything outlandish, then that is part of my job, and the trust indemnifies me for that.
Then a question about professional development. How do AAs demonstrate ongoing learning and professional demonstration?
So the Association of AAs, so we require 25 CPD points minimum per year. I roughly get about 50, I think, so I'm okay. We do lots of teaching. So we got a conference every year. We go to conferences every year. We do everything that consultant anaesthetists do. So if you've got audit meetings, your AAs will be there. Probably they should be presenting because they're part of your department. They're not out with your control. Sure, the same would be for the PAs. So we probably, because we don't get any SPA time, we probably get more CPD than most consultants, ironically, because we're able to kind of, when there's audit days, we're able to attend full audit days and we can go to other conferences. So we probably get in excess of 50 CPD points per year.
Thank you.
Yeah.
So we've talked a little bit about supervision. So Newman, do you have to have any particular training to be able to supervise a PA?
I've done my standard training. That's recognised as part when you're in your training, and then before you become a consultant. So I've done that, but as part of specifically supervising PAs, there isn't much out there, to be honest. And I think we are sort of, a bit like Adam. If you're supervising PAs, you're having to sort of learn on the job as well, actually. And you are pioneering quite a bit because I've had to sort of network a lot within the Northwest and speak to a lot of people and go to a few road shows and speak to other PAs and be part of there's a Northwest organisation for PAs, and just sort of have that two-way traffic of really understanding what is it that they can do, because, as Lee's saying, he is already very specialised as an anaesthetic associate, so that's a very niche, a very, very select, but as PAs, they're almost very general. They're generalists until they come into secondary care where they can sort of sit in a department and become very specialised as well. So I think it's very difficult to sort of train anybody to supervise for the whole gambit of even general practice or whatever. But I think I make sure that I have a sort of like a timeout session almost with all of my PAs every week in the middle of my clinic, just so that I can touch base with them, see what's going on. Good, bad, the ugly. I just need to know everything so we can do a business-like meeting and then really clear everything and then move on for the next week and be fresh. So I think because they're so young as a workforce, there's certain things that will come along your way which you've got to be pretty versatile and nimble to deal with. So I think that's what I've found probably is my best strength, where if I can be quick to get into a problem or deal with something, that's worked well. If things have been left or it's not been communicated with me, they sort of fester and become a bigger problem. So I think overall, we've had a fantastic experience, and like any new profession coming into being, they've got elbows out, so they're just creating a bit of nudge. They're nudging people out of the way a little bit. Some people are not going to like it, but overall, I don't think we've had any issues or any falling outs over it. It's just you just got to be very, very clear. What can they do? Where do they sit? And you've got to have a buy-in from the whole department. It's not just me. Yep. It's all of my other 25 other colleagues, consultant colleagues that I work with.
Well, that's a really good point. And we've talked a lot about sort of PAs, NAs and doctors, but of course in the multidisciplinary team there are lots of different professional groups. And the keynote speaker this morning spoke, especially in primary care, about the benefit of having different people. So how about integrating PAs with other professional groups, not just doctors in the multidisciplinary team? How's that work, Adam?
I think it very much in general practice, I think probably shows a lot more sort of variation in the way they operate than maybe wards and departments and secondary care do. It very much depends on how you run your general practice as an organisation. So in the one practice that I work in, it's pretty siloed. So the GPs do their work, the nurses do their work, and so bringing a PA in, they're sort of struggling to see where that fits in that spectrum. So they're just sort of treating them as a GP trainee, and they're kind of just picking off the GP's workload. Whereas in the practice that's established with PAs, we very much have a GP consultant model, and then you have nurses, GP trainees and PAs all sit equally underneath that. And you stream different workloads to them, and then they sort of get on with it autonomously and then come and feed back to the GP, who doesn't actually have anything booked in or anything themselves, because they are just there to supervise all of that work. And actually, in that practice, it works very, very well, because so the nurses and PAs can freely talk to each other about any problems that they have. We tend to have advanced nurse practitioners doing all of the triage on the telephone, and then they can then stream patients either to come and see themselves, either to come and see me as the GP on call, or to go and see the PAs. One of our PAs has developed a specialist interest in mental health, and again, with the continuity model, they are excellent at mental health, and people with depression can come back and see the same person and develop a bit of a rapport with them. So actually, having them as a profession in their own right means that we can stream the most suitable patients to them, but there is also interaction between all of the members of the team. So they integrate quite well like that.
So someone's suggested that we need to have a major or a PA or an AA in something like Holby City. They've obviously seen you on screen and think any one of you would be able to do that job. But do you think there are other ways that we can perhaps highlight the role of PAs and AAs? Our first question to any of you. What more can we do? Or do you think it's just you've all talked a lot about once they're in and you experience working with them, that's the best way to shine a light on the profession. But what more do you think we can do in advance of that?
I think locally the patients will become used to having their PA. So the guy that we work with is called Alex Strivens. They call him Mr. Strivens. So they'll say, I saw Mr. Strivens the other day, but now I'm seeing sort of Dr. Thomas. So I think you're very much aware of it if you see it regularly yourself. But I think the person who's asked the question is absolutely right. I think, governmental adverts, so they say, go see your GP. Maybe, go and see your GP or PA in your local GP. And people take a lot from the media, don't they? So having a high-profile character in a medical show that is a PA, people are going to then identify that with that person, aren't they? So I think it needs to be at a higher level to get it into the public consciousness that this role exists, what it is, and what they can do.
Fantastic. Difficult question now. So in light of PA training, do we think doctors still need to take 5 years to get fully trained?
I can sort of tackle that.
Well done, Ewan. Thank you.
I think, I don't think so, if I'm honest with you, because the way I've seen the PAs working right now, they do their 2-year course, they do a national exam, and then they obviously find, a post that they can work in. I've not seen that their training has necessarily been lacking in anything. If there was, then you could sort of understand that maybe they need a bit of training in X, Y, or Z. But I think from my point of view, if they've got those 2 years of core medical training and a medical model of training, I find that puts them in the right stead to sort of have that lifelong learning and continuous professional development, which is absolutely key. And I think going back to what was said about making sure that you do select the right PAs for the job that they're going to eventually do, it's key and critical that those PAs are selected way back when they come to university at that selection process. Because I have seen some, like I said, we see all sort of students, first and second years coming through, and you can you've got that intuition when you're a medic or working in the healthcare. When you see patients, within a minute you need to know what's their agenda, what do they want. So you can understand when a student comes in and he or she is sitting with you, you sort of can understand, what is their modus operandi, how do they do things, how do they see patients, what's their bedside manner. And you can just see that some are really lacking and some are actually really on the ball. So that variety that I see during their training, I think there's something to be said for that, really. I think that needs a little bit more fine-tuning. But I think the time that they have for their training, I think, is absolutely adequate, because whatever they go into, like general practice or in secondary care, that extra training will be provided for them while they're on the job. And I think that they don't really need much more than that.
Yeah. And we've talked a little bit about regulation. We've got a question here that says, is the liability to prescribe a limitation on the usefulness of PAs and AAs? So let's start with AAs. Lee, do you think that is a limitation on AAs?
It is, if I'm being honest, it is a little. So the things that I find deeply, deeply frustrating, that as a nurse, I can prescribe within my scope of practice, and I can go on the register with the NMC. I can prescribe whatever I feel I'm able to prescribe, and I'm held accountable for that. 25 years later, I can't write Amatop up for a patient who's got needle phobia. So it is a little bit, but you know, I'm an eternal optimist. There's ways of making the scope of practice work. You can write PSDs, patient-specific directives. Patient group directives don't work for anaesthetics, but they probably work more in private healthcare. Sorry, that wasn't a faux pas. I don't have any extra knowledge in GP practice, but patient-specific directives are a workaround. That's quite easy to do. It's very easy to do if you haven't got an electronic health system like Epic. It's very difficult to do if you've got a very integrated health system like Epic. But there are workarounds. So it does hold us back. It holds the physician associates back. We are hoping that with GMC regulation, that at some point there will be some good news. Maybe, it's going to take a few years, I think, but you know, there's no doubt that we all need to be able to prescribe within our area of practice.
And would you say it's the same for PAs, having that prescribing ability will make a big difference to the role?
Personally, I think, as you say, prescribing within your scope of practice, in primary care, because by default you are a generalist, your scope of practice is kind of limitless because you see people from neonates up to you know, centenarians. For me, especially when a PA is new, I find that the ability, the lack of ability to prescribe is the sort of safety net for them to come to me, discuss the case, think outside the box a little in terms of have you considered this, have you considered that, and then it is my name and my responsibility going on the script. Now, obviously, I'm coming as this from a health professional registered with the GMC who is supervising that healthcare professional. So it gives me peace of mind that anything that actually is being prescribed for the patient is being discussed with me and is being done by me. I obviously can't speak on behalf of the PA, who then might feel very frustrated that is the case. But I definitely think that being able to prescribe immediately out of training after doing their 2 years may be tricky. And whether that then implements when you have had a bit more experience would be the way forward. But certainly for me, I sleep better at night knowing that everything that's been prescribed has been discussed with me and it's my name going against it. But then that's just how I feel because I supervise so many nurses, so many PAs, and the trainees all at once. Hundreds of prescriptions get made every day. I feel happier knowing that there is a degree of control over that.
Thank you. And Newman, anything from you?
I personally have never felt it to be a hindrance ever. I think for us, as the PAs join us, because they need to build up that experience anyway, working within that environment, that sort of takes over all of their bandwidth. So if they had to prescribe as well, I think that would just be a little bit overload for them. But as they become more senior, I think I do get that feeling from some of my senior PAs where they wish that they could prescribe because it's something simple. So our workaround has been like, obviously, COVID is has been the accelerator in healthcare for good and bad things. But the good thing was, maybe it's a good, hopefully. We obviously were getting a lot of locums cancelling us last minute. We had PAs who were available to work. So on a case-by-case basis, we said, okay, you can come onto the junior doctor rota, not as a planned thing, but it would be a very, very ad hoc thing, literally less than 24-hour notice, for example, just so that you can support the registrar, so that poor registrar is not on his own or on her own to see the patients and prescribe things, etc. So what the registrar and the PA would do, they would double team. They would both go and see the patient. The PA would work up, do the management plan, all the stuff that needs to be doing. The registrar can focus on the medical aspects of things. They can prescribe, do the orders for the x-rays, etc., and then move on to the next patient. That way, we found that, and I did ask them, how did that work compared to when you have an SHO? And the registrar was like, actually, it was a little bit easier because rather than I could go in, see the patient straight away, advise what's needed straight away, much more effective care, actually. So again, that's a bit of a byproduct. But it was, it's interesting. I think we're coming across these problems, but they certainly very quickly become non-problems.
Fantastic. I mean, we've run out of time, so it's great to end on a practical solution and you know, providing better patient care. It's a really exciting time for the GMC moving to be a multi-professional regulator with physicians associates and anaesthesia associates coming on board in hopefully not too distant future. May I ask you to thank our panel very much for their time this afternoon. Thank you.